Hey guys, I'm Dan. I'm a first year physiatry resident in Toronto. So today I'm going to take you along for a full day on internal medicine. So you might be wondering, if I'm a physiatry resident, why do I do internal medicine? And the reason is that for the first year and a half of our training, we do something called off-service training. And what that is training in specialties that aren't our home service, physiatry. So we do training in internal medicine, geriatrics, plastic surgery, and other things like that, so that we can gain knowledge adjacent to physiatry, and as physiatrists, we understand other disciplines really well. So I want to take you along for this full day, and it's going to be a pretty cool day. It's my very first day of my last internal medicine rotation for all of first year. I have a great team that I'm really excited to work with, and I can't wait to bring you guys along. So I hope you enjoy the day, and let's get started. Okay, so hey guys, so we are in our morning rounds right now, and so what that means is we just take a look at the different patients for the day. We split up who's gonna see who, and I just wanted to go through with you what a general internal medicine team looks like. So we always have a senior physician working with us.
I'm Dr. Reppas.
Yeah, we have a senior resident.
And Ashish.
And we always have a couple of junior residents.
I am the Bill.
And I'm the other junior resident on the team, Dan, and then sometimes we'll have some med students who help us see the team as well. So I just wanted to thank these guys for helping out today with the video, and I'll take you guys for the rest of the day. Okay, so now let's talk about how I get to know patients on the first day of a new rotation. Because I've never met them before, I always review their consult note, which is their initial assessment. This assessment is done in the emergency department most often, and it's where we get to know the patient's medical history, surgical history, medications, and what brought them in for this specific admission. Then after that, I'll go into the chart and review each of their progress notes from the previous days. This tells me what's been happening on their journey in hospital. Finally, I'll go into the computer, I'll take a look at their labs and any x-rays, ultrasounds, MRIs, other scans that they've had done. Once all of that's done, then I'll go and actually see the patient. I'll chat with them and talk about how they're feeling today. And once I have a good idea of what needs to be done for them, I'll develop a plan, run it by them, run it by the team I'm working with, and then we'll implement it before the end of the day. Okay, so I just finished seeing a bunch of my patients for the day, and it's about time for lunch. And what's really cool about internal medicine is that the hospital actually buys you lunch. And so I know what you're thinking, hospital lunch, it probably sucks, but they get us freshie on Mondays, so super exciting. I'm really happy for lunch, and then I'll check in with you guys afterwards. Okay, so we're about to head to afternoon rounds where we're gonna review the patients for the day and decide what we do for them. But before we do, we have a little coffee break that I'm very excited for, so I'll take you there. All right guys, so coffee was acquired and we just wrapped up our afternoon rounds. So I didn't want to record during the rounds just because there's a lot of confidential information about patients, but basically what happens is that the junior residents review with the senior resident and the senior physician what our patient plans are. Right now, all I've got to do is wrap up my notes and wrap up my orders for each patient, and that's it for the day. But it's not it for the video. I saw some really interesting patient cases today, and there's some really cool medical topics that I wanted to review with you guys. So hopefully you'll take something cool away and you'll enjoy it. So let's start with our first patient case of the day. So this patient had a stroke, which is where you either have a blockage of a blood vessel in the brain or bleeding in the brain. And strokes can cause all sorts of different neurological consequences, but the one we're going to talk about today is a condition called aphasia. Aphasia is a condition where patients have difficulty receiving or producing language. And what's really interesting about aphasia is that it doesn't just impact the ability to speak language, but also written and sign language as well. The ways to break down aphasia vary, but the most common is to look at it as fluent versus non-fluent aphasia. Fluent aphasia means that the patient produces speech at a normal rate and rhythm, whereas non-fluent means that the rate and rhythm are abnormal. The most common type of fluent aphasia that we look at is something called Wernicke's aphasia. Wernicke's aphasia occurs when there is an insult to the dominant temporal lobe, which is where Wernicke's area is. Some of the most common symptoms we'll see is impaired comprehension, impaired reading and writing, as well as the patient making up words. They'll be saying so many different things that don't actually mean anything, so we call it a word salad. The main type of non-fluent aphasia is something called expressive aphasia or Broca's aphasia. And Broca's aphasia happens when there is an insult to the dominant frontal lobe in Broca's area. The most common symptoms that we'll see is the patient is unable to speak with a normal rate and rhythm, meaning that it's non-fluent, and they have difficulty producing any sort of spoken, written, or signed language. The patient that I saw today had expressive or Broca's aphasia, meaning that they had difficulty producing communication. But what's really important to realize with these patients is that they actually have intact comprehension. So they understand everything we're saying. They just have difficulty responding because of their Broca's aphasia. The second cool case that we saw today is very common in hospital, and it's a condition called delirium. Delirium is a fluctuating disturbance in attention, consciousness, and cognition, and it's very common in elderly patients, occurring in up to 50% of those admitted to hospital. When we're assessing a patient for delirium, we usually use a score called the CAM score. So the first element is acute onset and fluctuating course, meaning did the patient demonstrate a quick change in their cognition, and have they been getting better and worse during their hospital stay? The second element is inattention, meaning does the patient have difficulty paying attention? And there's certain ways that we would test this. The most common being naming the months of the year backwards, and if the patient can't do that, naming the days of the week backwards. The third element is disorganized thinking. So if the patient is speaking things that don't really make sense and they're jumping from topic to topic, we would call that disorganized. And finally, the last element is an altered level of consciousness. So if the patient appears excessively lethargic or very, very, very tired, these are the types of things we'll look at for delirium. And based off of the score, we'll decide if a patient is CAM positive or CAM negative. And if they're CAM positive, a diagnosis of delirium is suggested. Now let's walk through the workup for delirium. So one of the major things we'll do is have a look at the patient's medications and see if they're on any medications known to induce or worsen delirium. And I've included a list up on the screen of what we call psychotropic medications that are higher risk. The second thing we'll do is seek out any source of infection. So we'll often get a urine culture and a blood culture to see if the patient has an infection that may be affecting their cognition. The third thing we'll do is look for these metabolic conditions that could affect delirium, things like a low B12 or an altered TSH. We'll also look for environmental things that we can do to improve. So if we can have the patient's family visit more frequently, if we can get them a room with a window and have frequent reorientation, meaning telling the patient where we are, what time of day it is, what season it is, and writing all of that down on their board so that they remember where they are. And finally, the last thing that we would do is seek out any structural causes. So we would inquire about the patient's bowel habits, if they're having regular bowel movements, and we would also sometimes get a post-void residual measurement of their bladder to check that they're voiding okay, because if they're not, that could also cause delirium. So now that we've chatted about some of the cool topics from today, let's move on and see what we get up to for the rest of the day. Hey, what's up guys? So I've had this one in the drafts for quite a bit. It's been like 6 or 7 months since I recorded the rest of the video. So I just wanted to come on here and let you know that the last little while has been amazing in residency. I have so much more to update you on and I can't wait to take you along. Hope you have a great day. Take care.